Hello, everyone. My name is Larry Shulman. I'm a medical oncologist at the University of Pennsylvania, and I'm a former chair of the Commission on Cancer. I was fortunate to be in that position from 2017 to 2020, and I was succeeded in my position by Dr. Tim Mullett, who's with me today, who is the current chair of the Commission on Cancer. Tim is a thoracic surgeon and professor of thoracic surgery at the University of Kentucky. And we're very excited to have Tim as the current chair for many reasons. But one of the things that struck me when I first got to know Tim and actually went down to visit Tim in Kentucky was the remarkable work that he's done with a consortium of cancer programs in Kentucky that he's brought together to try to raise cancer care and its quality throughout the state of Kentucky. It's really been amazing. And so he's had a long track record of doing what the commission is trying to do, improve cancer care across the spectrum for all of our patients in the US. So he came well prepared, if you will. And I'm sure that had a lot to do with why we put the commission in his hands. I wanted to ask you, Tim, if I could, how you originally got involved with the commission, why you got involved with the commission, and you have plenty to do at home, in your home institution and your home state, but you've given so much of your time and effort in the previous years, and now, of course, as chair, that's a tremendous undertaking and responsibility. So how did it happen?
Well, Al Cohen, Dr. Cohen was our cancer center chair, director at the time at Markey Cancer Center. And through a leadership change, there was an opportunity, and he came to me and he goes, Tim, I'd like you to serve on our cancer committee. And I had been a busy cardiac and thoracic surgeon and had nose to the grindstone, moving through a number of cancer cases and developing some other areas, programmatic areas. And I said, well, that sounds interesting. Well, what is it? And so he said, well, they meet about every quarter and they go over some standards and make sure that we're in accreditation. And I said, okay, what would you like me to do? Well, I'd like you to be the chair. And so that was my introduction to the Commission on Cancer. And so I had a lot to do because I could barely spell CoC at the time. And I had to learn where we were in that picture. And frankly, it was only a few months later that the next chair, the chair to be actually came in and was my surveyor in our program. And Dan McKellar came in, and we did not have a stellar program. We had some work to do to catch up with our deficiencies and to really restructure. And so it was a wake-up call for all of us. And I've watched many programs go through this same thing. And frankly, it was a blessing for us to see exactly what accreditation and the power of standards can do. Because this morning we had our, this is probably 15 or 16 years later, we had our cancer committee meeting. I'm still the chair, and I watched 45 people participate in a Zoom conference and give stellar reports on the activities that they're doing. And they're so proud of what they accomplish in our program, and they should be, because we are, again, using these standards to drive the quality forward. And so as I went through my work as the CoC chair, and then began to develop more of an affiliation with the commission itself, and got appointed as a commissioner and then as the state chair for Kentucky, I then began to see the value of being able to link these CoC programs and to be able to see how we all speak the same language, we all use the same structure, and we were developing this network. And I said, it's a beautiful marriage for us to be able to mandate that to be a member of our affiliate network, you have to be CoC accredited. Because if we're going to hang our sign on your door as a member of our network, we want that to represent quality. And the standard that we chose was the Commission on Cancer. And that became such a drawing card that the network has grown. And so these two elements are linked hand in hand.
That's really terrific, Tim. And your work in Kentucky has been remarkable, and really stands out as an example of what we all need to do more than we do. We know that a lot of the disparities of care have to do with rurality, with poverty, with programs that are small and struggling to do all the things they should do. And clearly the consortium that you formed in Kentucky has made huge strides in bringing better cancer care. And now you're doing it for the commission, not across your programs in Kentucky, but across 1,500 programs across the U.S. So, you know, becoming chair of the commission is a big undertaking in any year, but you became chair in the middle of the COVID pandemic. Actually, I don't know when the middle of the COVID pandemic is because I don't know when it's going to end, but we were deep into it in October when you took over as chair, and that's obviously created tremendous challenges for all of our cancer programs and for the commission. I don't know if you want to make some comments about your thoughts about that, and you know, and how that's influenced your first months as the chair.
Well, it's how it's influenced every aspect of what we do. It's because as we went through as your chair-elect and then now as the chair, the transition from surveys in person at all of our 1,500 programs to not being able to do surveys at all, and then being able to pivot to develop a virtual format for surveys, something that we had considered in the past, but COVID has, in a way, one of the silver linings, if you will, has been the impetus for change, and it's forced us to be able to say, okay, we can't just wait until this is over. Our cancer programs need guidance, and we have these new standards that are going to go forward. We have made changes and accommodations as far as the application of the new standards and as far as surveys, and certainly there's a lot of accommodation for all of our programs because every one of them has been influenced by both in patient care, but also in the structure of their cancer program, and furloughs and redeployments of critical personnel to be in the places that they need to be. But watching this and working with our accreditation committee, Jim Harris and his team have been amazing with the field staff to be able to get them moving forward and get them functionally and virtually back out to these programs and continue that level of leadership is critical. And it's been so well received by our programs that I have no doubt that we're going to see a hybrid form of our site visits going forward. And that's probably healthy. And additionally, one of the early elements that came up probably as Dr. Sharpless, the director of the NCI, pointed out that screening had come to an appropriate complete halt. Screening is one of our primary standards, along with prevention in the continuum of cancer care. And yet we were now not doing screening at all. If we aren't careful, then that's going to lead to a dramatic rise in late stage diagnosis and an increased mortality associated with those cancers that are often found in earlier stages, such as breast and colon cancer, and certainly in lung cancer, an emerging field of lung cancer screening that is going forward since its approval and CMS funding and general acceptance of that. It was on a slow trajectory to begin its process, and we really didn't want to see that get stalled. And so moving in the direction to understand the value of return to screening has been a primary objective as we've taken this on, and trying to allay some of the concerns of not only our programs and our providers that are engaged in these facilities, but also to be able to carry the message to the patients. And so I think it's important that we allay concerns, get these people back into screening. And as you've mentioned, the disparities that are associated with that are often aggravated in times of stress. And certainly it's important that as we go forward that we recognize not only that there's disparities in care, and you mentioned several of the determinants of that, whether it's rurality or poverty, income, and education levels and trust of the medical system, all of those need to be addressed so that when we have these forces against our care, then we don't actually exacerbate the disparities that exist, but we continue to try to mitigate that. And so it's been, the COVID pandemic has been a change. It's changed not only our surveys and how the CoC responds, it's changed how each one of our programs responds to virtual care. And I think that too is an element that was a force that drove us into virtual care. We were tiptoeing our way towards virtual care. You've talked on this in the past couple of years to be able to help us understand that medicine is a slow moving ship, and in fact it turns slowly, and to move away from our conventional care that we've all been used to in the clinic and in the hospital, and be able to really adapt not just a virtual visit to say hello to someone on a TV screen, but or a video screen of some kind, but to actually be able to provide care virtually. These are the forces that are now in our hands, and that we are more than just a video version of a clinic room, but we actually are going to be delivering care in a much more novel way. And I think cancer stands in an optimal position to be able to drive that forward.
You know, just on a personal note, Tim, because I think this really emphasizes what you're saying. In the months after you took over, I oversee 6 hospitals and 6 cancer programs, all of which are independently accredited by CoC. And we had 4 accreditation visits in the months after you became chair, and the message was clear. The message was, you know, we appreciate the fact that you've done unbelievable things to continue to care for your patients in the face of the COVID pandemic. But we have to remember that there are reasons why we have standards, there are reasons why we've determined how care needs to be provided to have the optimal outcomes. And cancer doesn't go away just because of the pandemic. So the message from your site visitors was clear. It was appreciative of everything that we were going through, but emphasized the fact that we couldn't take our eye off the ball. And we thank you for that. I just wanted to end, Tim, if we could, on a personal note from your side. You know, many of us, myself included, have spent our careers on one side of the exam table, if you will, as physicians and cancer providers. But you've had the chance to view it from both sides. And I was wondering if you could just share that with our listeners today, and what effect that's had on you, thinking about your role as a cancer physician and how you view cancer quality, how it should be delivered.
Oh, thank you, Larry. It was already an interesting time back in 2012 when I was deployed in Afghanistan as a medical officer in a forward surgical team. But coming home, I knew something was wrong when I thought I was losing weight because I was just exercising. But when I felt the mass in my liver, and then knew that wasn't going to be good, and then finally saw the ultrasound and then the CT scan, and clearly I didn't think that with the evidence of metastatic disease, from whatever source it was ever going to go well. And so that was a difficult New Year's to come home to in 2013. But the biopsy on the 2nd of January came back with a GIST tumor, a gastrointestinal stromal tumor, and it was metastatic. I didn't have an opportunity for surgery. So a few days later, the tests came back that indeed it had a favorable marker that allowed it to be treated by some of the most original targeted therapy we've had. And so as it turns out, 6 months later, the tumor was not active on the PET scan, and even as recently as a few weeks ago, the scans are stable. And so I continue on 1 pill a day, and but that period of uncertainty was unbelievable. The not knowing where I was going, where my family was going to go. We had done all the things that were necessary to take care of them, but at the same time, it was not the time that we were expecting. And so when things turned around, and all of a sudden we had a whole new perspective that this was going to be okay, at least appears to be even today. I really felt a dramatic pressure to say that we need to do something different in the way that we're delivering cancer care. And so I think that was a huge force for me to be able to turn on a lot of emphasis towards supporting our programs in Commission on Cancer, recognizing the value of changing what could happen in not just my life, but in so many more people. And it also changed my focus from saying that I can fix a lot of people by operating on them one at a time. But I may be able to fix more people if I can make changes like we're discussing today, changes that are going to drive programs in a different direction, changes that are going to recognize differences in care and address those differences in care so that those disparities go away. And so I think that being it was timing. It came along at a time that it drove a transition in my practice. It drove a transition in my life. It drove a focus in my life to be able to say that I'm going to make a difference in what we do with cancer care. So, and the commission has been great to be a driver in that. My institution, University of Kentucky, has risen to the occasion and has recognized that if we put emphasis on the areas such as network development, then it's going to make a difference as far as the impact in the community. And so, and it has, and we've shown that. We've been able to document that in a number of different areas. And so being able to understand the angst that the patients go through and their families go through and the uncertainties of all of that, being a cancer patient and being a cancer survivor is one of those perspectives that I don't wish on anybody, but it definitely changed the way that I'm able to see the spectrum of cancer care.
Well, Tim, thank you so much for sharing that personal story. And, personal crises like that affect people in different ways, and they respond differently. And the fact that you've turned around, as you described, what was a pretty scary situation, I'm so glad you're doing well, most of all, but you've turned that around to just making you more devoted to helping more people and to really leading our nation's cancer efforts. We're so grateful for your work as chair, for your leadership, your vision, and we're glad you're going to be around as chair for another few years because we really need you. So thank you so much for spending the time with me, for sharing your stories, but most of all, thank you for everything you're doing as chair.
Well, thank you, Larry. It's great to see you. I look forward to continuing to work with you.